Hello, what up, friends? Oh my, wait just a few minutes till some people jump on here, but I need to say first and foremost, sorry I missed last week. Well, let me back up a little bit. If you're just stumbling on this and we haven't met yet, I'm Bree. I'm an RN, NP mentor, interview strategist, content creator, educator, coach, all of the above. And I come on here live once a week when I'm getting ready for my night shift in the ICU because I'm a critical care nurse practitioner and just monologue about what's going on and talk about some educational stuff. So the topic that I have in mind today is what I wrote about in the blog this week, which is lactic acidosis. Hey, Mr. Midwife, glad you're here. Sorry I missed y'all last week. So we will plan on doing a little bit of talk about lactic acidosis in respects to, the patient who's in the hospital, whether they're in the ER or on the floor, in the ICU, whatnot, and what it means, what it indicates, when to freak out, when not to freak out, what the different types of lactic acidosis, and what you can do about it. So that's kind of the educational topic. As always, please jump in with any questions, anything that you want to ask. I am pretty much an open book. We'll tell you anything you want to know. So let me get a little housekeeping out of the way first, though. I have to apologize for last week. So we have an ongoing saga in our finished basement downstairs that is requiring major repair. And I woke up last Thursday morning to my husband saying, I'm glad that the guys didn't wake you up yet because I know you got to work tonight, but we have to get out of the house. I was like, excuse me, sir. I had to spray some stuff that wasn't safe to inhale, so we had to leave for 24 hours. I'm like, this is incredibly inconvenient. This is my live day. Sir, this is not going to work out. Such is life when you are a homeowner and everything decides to die at the same time. Clayton, I cannot tell you how happy I am that you are here today, my friend. I am glad to see you on here. If you guys don't know about Spirit Medium Clayton, you should. He has a YouTube channel as well. He is a psychic medium, and I'm a little bit obsessed. I think you should be too. He's got quite a gift. And Mr. Midwife, as always, is here with us, and he also has a YouTube channel talking about all things midwifery. So the other housekeeping thing I wanted to talk with you guys about, maybe I'll ask later on when more people are on here, but is anybody going to a nurse practitioner conference this year? Anybody going to a CME? I think I brought this up, the idea of it last week. I was planning to go to Montana in the summer to a critical care conference. I go to some type of critical care thing every year. Last year I did ER, which was very interesting. But not going, can't afford it. They're pricey. That's why I canceled the Montana thing, because I get like $2,500 for my hospital, which is usually pretty much will cover everything for the most part, depending on where you go. I had no idea how expensive Montana is, though. Like the flight in and of itself from Georgia, hey Scott, was like $650 plus oh my God, even the cheapest place I could find on Airbnb was still like $2,000. Like, are you kidding me? So anyways, I canceled that, and I am now instead going to go to the AANP conference in New Orleans, and I've never been to AANP. Super excited about it, but a little bit intimidated because it looks massive. It's at like the what do they call it? The convention center. It's huge. There's like 300 different breakout sessions and all these people. I'm like, and I think I have to go by myself. I'm trying to talk my friend into going with me, but I'm not so great on the like traveling by myself front. I don't know. So anywho, we'll see. So I'm looking for some friends. Y'all, let's go to New Orleans, end of June. It'll be hot, but it'll be fun. I'm sure it'll be fun. I've never been. I'm super excited. I've heard the food is amazing. At least that's what John says. Although I have a white girl palate, so I gotta have everything kind of bland. But I'm still looking forward to the food. And they've got some pretty cool topics, so I'm excited. And I also bit the bullet and paid for some advertising, which is a lot more money than I've ever spent on advertising. So we'll see how that goes. Okay, so all the peoples are here. All right, so I guess we will just kind of jump right to it. So again, I'm thinking to talk about lactic acidosis, and depending on how much time we take up or what questions come in, I may do a little bit of talking about what I had planned on last week, which was decision fatigue, which is a real problem. Probably the biggest problem I had as a new grad NP and did not anticipate. Okay, so anyways, All right, let me get started on a little bit of makeup here first. I did go ahead and moisturize, and where is my? I also got to tell you, my life has finally been handed back to me because I finally finished the book. Holy crap, y'all! I don't know how people like authors, like real authors that have deadlines, the pressure. Because this time, so I wrote an H&P cheat sheet, like I guess it was maybe 2 years ago, and it's kind of what I give my students. It's like what I teach for new providers in the ICU. It's the top diagnoses you see in the ICU, how to work it up, what to look for, and what to put in your note. And so I decided it's been really popular. So I decided to do a second one, and this one was really hard. I don't know why this one was so much harder than the last one. I think because I specifically said, okay, I have a date in mind. I want it to be done by this date and launched. And I was kind of holding myself to it. And man, the pressure of that. And the fact that just by nature, the problems that I chose this time, they were way more complicated. So I wanted to, do a ton of research. And it just turned into like a whole thing. It turned into a whole thing, but it's done. It's done. It's live on the website, and I launched it last week, and I feel like I can take a deep breath again. Scott said, I just realized this brings me back to talking to my mom when she put her makeup on, warm fuzzies. Okay, I had that same thing. So, except my mom was not a makeupper, but she was also, I think I've told y'all this a million times, but she's a nurse midwife, and she loved to decompress by coming home and sitting at, we have this parlor, because, we're in the South, it's a parlor. It's not a den, it's a parlor, in the front of the house. And it had the only computer in the house because I'm old. And at that time, she loved to play mahjong. You might know what that is, the tiles, the Chinese tiles that you move around. It's kind of almost like a card game, but multidimensional. And she would sit there for hours after her shift and just mindless zone out. But every teenager in my house would go and sit in that dark room with her on the couch and share the story of our lives. Warm fuzzies for me too, for sure. Yeah, my girls come in when I'm putting on makeup. Actually, they tend to come in when I'm in the shower. Which is when I get home from work and I immediately go upstairs and jump in the shower. And you see the shower behind me, right? There's no privacy there. So we're kind of an open family, Like I gave up trying to have privacy when I had toddlers. Like, oh, forget it, Everybody's going to see what mama looks like. But yes, that's when they come and talk to me too, when I get home from work. Clayton says, I know it's so hard. I'm writing a book that I'm channeling, and it's so hard. I've had to change things. It's so true. And then you go back, like you've got it all done, formatted, printed, and you see something in print, you go back and change it again. And actually, I really hold myself to a high standard for this. So I had some peer reviews, and I had to wait on the peer reviews to come back. And yeah, it's just a thing. It's a whole thing. But I really, really love, if anybody else is in the entrepreneurial space, I love this type of education, because it's like one and done. Like you do it, you spend all this time on the front end doing it, but once you're done with it, you're done with it. And you can sell it. A lot of people want things digitally these days. I sell way more digital books than I sell physical books. And then it's just like an instant download. So it's great. I mean, it's really, really a great little source of background revenue. Once you've got it done, you just got to get it done. At least we know you're clean. That's true. I shower a lot, especially after coming home from the hospital. Last night, well, no, I didn't work. I worked during the day yesterday. Yesterday kicked my booty. It was so busy. But I came home and I had blood in multiple spots on my scrubs. Multiple spots. It's been a while since that happened. And I thought, I hope it comes out. Some of my favorites. Yeah. Nursing. You got to get in and get all the germs off before you touch anything. Run naked. During COVID, I would run naked from the garage to upstairs because I thought it'd be on my clothes because the fomites spread. Yep, I was that girl. I also moved out of my house for 6 weeks though, so Okay, I'm supposed to be talking about lactic acidosis, but I'm gonna put my glasses back on for that. So the reason I chose this, I mean, I always get my inspiration, it works, but hang on one second, I gotta find where all the brushes are. They're hidden behind the computer. Is that one of the roles that I serve in, I'm a critical care NP. One of the roles that we do is that we respond to rapid response calls. Some places call them MET calls, medical emergency calls. So it's the precursor to a code where, a patient's sick and something needs to happen and you need attention quickly. So most hospitals have this, and they employ nurses who are highly trained, highly protocolized to go into the room and assess the situation and do what they can to prevent it from escalating. Well, now at our hospital, the NPs are responding to them also, which has actually worked out really, really well. And turns out has been super rewarding for me because I get to use a little bit of that ER stuff that I haven't used in a long time. It's that rapid assessment of, okay, you're walking into a situation completely blind. You have no idea really what's wrong with this person. You ask the 50 million people in the room what this person was admitted for, and nobody knows. So you are truly, it's like them walking in the front door. So I like it. But what I find is that, and this comes across the boards, okay, I'm not pointing fingers at any one particular person or type of staff member, but across the boards, people freak out when there's an elevated lactate level. They just do. It is a bad omen. It is instilled within us that when the lactate level is 4 or greater, we need to panic. And the amount of concerning conversations that I get from people, oh, this patient has to move to the ICU, the lactate level is high. Or calls from the ER to admit a patient who has really not much else going on except an elevated lactate level. I think they should come to the ICU. I think the hospital is not going to take them. Why? Because the lactate's up. So there's some misconceptions out there, and it is a total culture shift. And I know exactly why this happened. I mean, this is totally my opinion, but it's right. And that is in 2000, was it 2001? I gotta look up. Yeah, 2001. There was a research article that came out that was spearheaded by Emmanuel Rivers, who actually heard speak once, who did this study, and there were some pretty strong indicators that early goal-directed management of sepsis leads to improved outcomes. It was groundbreaking, and it still is for many reasons. And I think the takeaway from that is early goal-directed management, identifying it early, getting the cultures early, and starting them on antibiotics early. To me, that is a takeaway. And finding the source first and foremost. So it's kind of bringing awareness to it and acting quicker. But the fluids, that's the problem. Okay, this is my problem. So I'm going to read it to you because I don't want to misquote anything, because this was 2001, and ever since then it's been like, there's a lot of dialogue. There's a lot of dialogue, some good and some bad, about everything that has happened as a fallout of this protocol. So, okay, this is what it was. The thing in this article that I think impacted and changed everything, possibly in a negative way, is this. They quoted that the physical exam findings are subpar for directing resuscitation, and that measures such as lactate, SCVO2, mixed venous, base deficit, and pH are more accurate measures of adequate treatment. And that's the problem, because it took people from a place of saying, let me do a full-on assessment of the whole situation, all the labs, all the diagnostics, the clinical exam, all the picture that's coming up here. And instead of using that, let's take some numbers and use those numbers to say something's wrong with this patient and something needs to be done. And y'all know how I feel about that, about anything I talk about all the time, is that you can't just use a couple pieces of data and treat them. And so anyways, that was the outcome of this article. And because of that, most all hospitals in the US adopted these guidelines that say, okay, there is a time frame from the moment a patient walks in the ER. Within 30 minutes, they got to have labs. Within an hour, they got to have antibiotics. And within 2 hours, you got to have given them 30 cc's per kg of fluids to resuscitate, to bring that. And they use lactate as a marker for whether or not they are adequately resuscitated. That's how it started. And then it just kind of snowballed from there. And suddenly lactate became the sign that everybody wanted to avoid and stay away from and get freaked out when they saw. So what we find now, 23 years later, is that the fallout of this is that people don't do the full exam. Now, I will say, since this was in a research study that was done by this group. It was adopted by the SCCM and critical care societies. It has since been, I think, 2 or 3 times addended. The most recent one was 2021. And in there, it says there is weak evidence to suggest that using lactate as an endpoint measurement is successful. And they've said that kind of all along. They didn't quite adopt the Manny Rivers endpoint philosophy per se as much as that article did, but many hospitals did. So anyways, hey, 802 Merce, glad to see you. It's morning time wherever you are, I guess. It's 3:15 for me here in Georgia. So we're talking about lactic acidosis and why it may not be the terrible bad omen that everyone thinks it is. Hang on a second, let me clear the throat. I get really dry when I talk a lot. There are multiple types of lactic acid level. I'm saying that wrong. Multiple causes for an elevation in lactate. And only one of them is really concerning. The first one I want to talk about, and this is something that I wouldn't say I hear about or see about all the time, but it happens often enough that I think we should bring awareness to it. Pseudo elevation, meaning the lactate is not actually high. There is a lab error. And these are things like the tourniquet was on too long or too tight, or the sample was not sent immediately or was not stored on ice. How often do you think that happens? That explains a situation where you draw some labs and you have a lactate that's high, and then you recheck it 2 hours later and it's like completely normal. Like you had like a 20 or something like that, and then it's 1. Well, it never was probably actually 20. Same time, just worked overnight. Oh, you're a night shifter like me. Okay. All right. Yeah, usually after a night shift, I sleep in till like 11:30 to 1:30 on a good day. Scott said, this is interesting because I never worried about any endpoint. I was on the front end of EGDT, say that 3 times. Give fluids now, diurese later if necessary. And that still is, okay, that still is what you do when someone is hypovolemic or early septic. However, it just shouldn't be like adopted by everyone who has an elevated lactate level. It's not the lactate itself, it's the diagnosis, it's the sepsis, it's the hypovolemic shock. That's the piece that kind of is the takeaway here. There's one other thing that will cause a pseudo elevation, and that is if you obtain the sample from an ischemic limb. So the patient who is found down, who's been laying on their left side, don't draw it from the left side because there's a chance that there's some compartment syndrome or poor flow, some arterial damage. So those 3 things can make the lactate level be high, and it's not, in fact, actually high. Okay, so that's that. Then there's type B and type A. Type A is the bad one. We'll get to that last. Type B is all the middle ground. This is the majority of the people. These are the majority of the calls that I get. Well, a fair amount of the calls I get. So what should we be looking at? MAP or somewhere, whatever. I'm going to get to that. In the end, I'm going to talk about what you should do and how to treat. So Type B represents local but not global tissue ischemia, so it's less worrisome. I mean, first of all, I should say lactate is the end product of breaking down of anaerobic metabolism. So when there is not enough oxygen, when there's not enough flow, when there's tissue ischemia, so you worry about organs dying. Definitely type A. Everybody in my family says I'm type A, but I say I'm not. I feel like I'm type B, which would fit because it's also the really confusing one. It's the one that everyone gets tripped up by. Okay, so type B, look for signs. All right, so when you're trying to sort out whether it's a type B or type A, start by sorting out whether or not you see signs of end organ, like systemic end organ damage. Okay. The best way to make this easy to think about for me is to think about the patient who's had a cardiac arrest. They were down for like, I don't know, 30 minutes to an hour. Okay. What do you worry about happening after that person is resuscitated and they get a pulse back? You worry about the organs that are starting to fail. And the organs that are not protected when there's low flow are going to be first your digits, your extremities, your brain, your kidneys. Then you also have liver failure, and you can have mesenteric ischemia where the gut starts to die and you have GI bleeds. You can have heart failure. You can have pulmonary failure. So all of those things that start, all the organs that start to die because they're not getting perfused, that's what you worry about in global tissue ischemia when a patient has poor flow or high extraction. So if you're between type B or type A, look at the situation. Does the patient have good urine output? As Scott pointed out, what is the BUN creatinine looking like? Are they confused? Are they in a coma? Are they in their right mind? Are they having abdominal pain? Are they having GI bleeding? Are the LFTs high? Do they have right upper quadrant pain? All the signs that you would look at each particular organ to determine if it's taken a hit or not, that's what you'd be looking at. Is the blood pressure low? All of these kind of factors. If not, you're probably dealing more with a type B, which is the less concerning, but it can be sort of concerning. So I'll get to that. I'm being very confusing today. Because type B does not raise high concern for end organ damage, and therefore it does not necessitate aggressive resuscitation. I'll come back to that. These are the patients who tend to have just a little extra lactate, like that 2 to 6-ish kind of range, somewhere in there, just a little bit on the higher end. It may remain very stubbornly elevated. It may be very hard to treat it because unless you take away what caused it, which I'm going to get to in just a minute, then it's just going to be there. And a lot of these situations, you can't fix the underlying problem. You just have to put into context whether or not this should induce panic, concern, or just a little bit of concern. So here are the causes of type B lactic acidosis. So local tissue hypoperfusion, so hypoxia, seizures, hypothermia, like with a lot of shivering, excessive exercise. One time I worked at a level 1 center in Atlanta, and a young man was 26 years old and he was training to be a police officer, and he was doing a lot of running and he was taking a lot of protein powder, and he did excessive running to the point that he developed severe lactic acidosis systemically, not just locally, and lost both of his legs. I will never forget that. To this day, I've never forgotten that. There can be compartmentalized areas where there is such edema and such severe ischemia that you lose the limb. Think about the patients with dialysis who've started losing limbs because they're not getting flow. They've got poor flow. They got terrible peripheral vascular disease. They can't get flow there. He literally ran his legs off. I pray to God he's not someone who would ever watch this, because not that, but it was very, very, very tragic. Young man. Other causes, metformin. So at high levels, so think about the dialysis patient or the patient with renal failure or AKI who's on metformin. So if you are a layperson and happen to be watching this and you are diabetic and you have kidney disease and you're on metformin, go talk to your doctor about whether or not that's the right drug for you or not. Because at a certain point in time, it can always tip over the scales and cause a pretty severe lactic acidosis, which is weird because these people are in shock in the hospital, but yet the shock doesn't induce end organ failure. It's weird. I won't get into it because it's super confusing, but it's weird. DKA, this is the classic, right? This is the patient who's got a little bit of a lactic acid level. Their pH is probably really low because they have a metabolic acidosis, and they're fine. They're fine. They're not confused. They're peeing just fine. They don't have belly pain. They don't have any signs of someone who's in the throes of death, right? So this is not someone that you need to pump a bunch of, well, you do DKA, take it back. You do need to pump a bunch of fluids in for the DKA, but not for the acidosis. It's confusing. But they're not someone that you need to put on a bunch of pressors and rush to the ICU. Okay. This is someone who is breaking down energy because they don't have oxygen delivery. So it's not as sick. It's not as serious. Yeah, I would imagine so. His body probably did like fire. Cancer. This is the one. What do you do about cancer, right? You can't take cancer away. Cancer patients often have, and it's certain types of cancer more than others, and I didn't write them down, but you can do your own research. But certain types of cancer, you will generate a pretty decent lactate. It'll be around 4 or 5, and it will never go away. No amount of fluids, no amount of nothing that you do to resuscitate this person is going to make that lactate go away. It just is. And this is probably, okay, welcome back then. Well, okay, yeah. So probably one of the most common things that I see and that you would see in the ER are people who come in intoxicated from alcohol or methamphetamines or Coke. But what we see a lot around here is meth and alcohol. 9 times out of 10, these people have a generated lactate. It is 4, 5, 6, 7, 8, maybe even higher than that if they've got shock associated with it, which is kind of a combined effect. So they may actually have global tissue ischemia as well. But if they don't, say they're just drunk, their blood pressure is stable, they may be tachycardic because they're drunk, but they may have a lactate level. They don't need to come to the ICU. They don't need to come to the ICU, not for the lactate at least. Merce 802 Merce says, love this topic. I literally just had a case as the stat nurse found down grossly hypoxic in the field. Recent COVID maxed on high flow. Labs showed the house with yeah. And COVID, interestingly, because you are doing so much, most of these people are very, very tachypnic. They're using a lot of accessory muscles. So sometimes they'll generate lactate just from the exercise of breathing. But yeah, hypoxia will do it. Ingestion of toxins or drugs. So again, we already talked about metformin, Depakote, linezolid, nipride, propofol, heart therapy. That's your HIV therapy. Cocaine. I already talked about the meth and the alcohol. All of those things will raise your lactate level. And I didn't put it on here, did I? I can't put it on here. Epinephrine. Epinephrine is an independent factor in driving up your lactate level. So that gets really confusing, right? Because if you're on epi, you're in shock already. There's not a lot of reasons aside from asthma why you'd be on an epi drip. So you're on epi, your blood pressure is low, and your lactate keeps going up and up and up. Well, is that because the blood pressure is getting worse and the shock is worse? Or is that because the epi is making it worse? It's not always very clear. With cancer, why chronic elevation of the lactate? I don't know that I know the answer to that. I'm trying to think through. So you are growing a lot of abnormal cells, so you have high growth. I don't know the answer to that. I don't want to pretend like I do because I don't know the answer to that. I read at least one article talking about this, and we looked into the different types of cancer, and I honestly just don't remember. I mean, there are a lot of cancers can drive it up. Looking at urine output vitals trend with epi. Yeah. And also, so if your epinephrine drip, like if you're weaning it and the blood pressure is getting more stabilized and your lactate is staying the same or going up, then it's probably not the shock, it's the epi. You just need to come down on the epi or switch it to something else. Assuming that it's really concerning to me, honestly, what is concerning about high lactate? It's not the number, it's the state that it indicates the patient is in. So if I'm looking at a patient and they're weaning from pressors and they're looking better, what do I care what the lactate number is? I don't care what it is. The problem is everybody around you will. Every single person around you, all the consultant, all the people, everybody, every nurse will bring to your attention that the lactate is still high. And do you want to give another 500 mLs of NS? No, I don't. So it's your job to understand why it is there and then explain it to everybody else in a way that they hopefully will think comes across as respectful. It's a symptom. Exactly. Look at your patient. I always say that. Look at your patient. There's no one like diagnostic for pretty much anything. And there's no easy ways to just say something is written. You have to look at the whole picture of everything, which is why medicine is so complicated. Okay. And then the other things I wanted to say about type B is this. So you'll have situations in which someone may generate a lactate and they just can't clear it well. So liver failure, renal failure, alcoholism. Typically liver failure is the big one because the liver is what helps you clear the lactate. It helps break it down and get rid of it. Decreased metabolism also. So thiamine deficiency or alcoholism. So again, alcohol, that's the takeaway because that's probably one of the most common calls I'll get from the ED is, I got a guy down here, his CWAS score is moderate. He's kind of managed okay on a little bit of Prestex. He could probably go to IMCU, but I think they're going to balk because his lactate is 6. And I'm like, well, I've seen a handful of patients in this situation, and I'm not blaming our ER physicians. I get it. They get pushback from everybody they talk to. It's just trying to explain the rationale of why I don't believe that this lactate level really represents anything severe, and it's going to be there for a little while because he's still drunk and his liver's probably not in good health. So it's going to be there for a while. It's going to be very hard to clear it. Sounds like fever, everyone gets, it's for sure. Okay, so Nurse Scott said, sounds like fever, everyone gets all concerned about fever. I will second this. My ICU training started in a surgical trauma ICU. So I was trained by surgeons, and I've just never forgotten it. But like, a fever is there for a reason, right? It is a natural compensation. Our bodies are just designed so perfectly. I really, I have strong faith. I believe that God has built our bodies exactly the way they're supposed to be. And God said, when you get a nasty bug in your body, you raise the temperature and you burn that crap out. So, why are we trying to get the fever down? I am always kind of surprised at how often I have to remind people, I'm not worried about that fever unless he's tachycardic, unless he's seizing, unless it's having some detrimental effect on something else that we're doing. Interestingly, a fever will also shift your oxyhemoglobin dissociation curve. So the patient who's hypoxic kind of likes being a little warm because it offloads oxygen a little easier. So fevers they're not that bad. I mean, I know they feel like crap, but they're not that bad. Okay, so where was I at? I lost my train of thought. Okay, so that was type B. That's all the confusing stuff, right? And the reason it gets even more confusing is sometimes you can have a type B and a type A, or you have a patient who let's go through type A first and then we'll get to why it gets confusing. But type A, these are the ones you worry about. These are the patients that you get concerned that things are looking pretty bad. But again, you, being the clever and astute clinician that you are not the kind of person who's calling from behind a desk for someone else to go look at someone because they got called because of a high lactate. You are the one who went to evaluate your patient, and you were standing at the bedside and saw that, oh, yeah, well, there's other things to be concerned about here too. My blood pressure is low. He's tachycardic. He's confused. And he's anuric. Yeah, it's a type A, right? And he's got signs of end organ damage. He's not looking so good. This is the whole picture. This would probably be one of the biggest errors, when I get these calls. Can you consult on this patient whose lactate is high? Well, have you seen the patient? Sometimes I think when I come on social media, I come across like a raging jerk. And I really hope that nobody who's ever called me with this is watching this. Because I get it. Okay, so type A. More worrisome because of the global tissue hypoperfusion and organ failure. And the causes are below. All forms of shock. All shock will lead to an elevated lactate and concerns of end organ damage. Cardiac arrest, independently, aside from low blood pressure, peri-intubation problems, hypoxia, shock, independently cardiac arrest, we'll call it, probably because you're like damaging the muscles. Prolonged hypotension, diffuse trauma or burns, anemia, carbon monoxide poisoning, cyanide poisoning. Those are interesting cases, which you never see, so I won't get into those. And then I lumped also into this regional complications, which is going to sound a little bit contradictory to what I told you earlier. But when you get into a situation of like critical limb ischemia, where you're about to lose a limb, to me, that is, it's life and limb, right? While they may not have systemic end organ failure, they have, a clot, an arterial clot, or they have a stenosed vessel that at this point has just no longer got collateral circulation, and there is no flow. We see, I'm pointing to my feet because it generally happens at the feet. But, there's no flow down there, and they are going to get ischemic, they're going to get gangrenous, and they're going to lose that limb. So to me, that is right up there with you should be very, very concerned about it. While they may not be going into shock, the blood pressure may not be low, they may not be confused, they may not have the other like systemic signs, that limb is dying. You have to, I work with a hospitalist that grills the ED docs when they throw up and admit. I mean, you got to ask why, It's always good to ask why. I think it's just knowing how to ask why in a polite way. I was actually just talking with someone else about this, y'all, about communication. It was, who was, oh, it was a client that I had. And we were talking about how to communicate with, particularly with physicians who have a little bit of an ego, and how do you handle that? And she kind of gave me her solution. And I was like, I mean, I think it's great, and everybody handles it differently. She said, I would just give them facts. I'm like, problem is, sometimes even when you just present facts, they see it as argumentativeness and they don't really hear it. So my strategy, honestly, I don't know if this is healthy or not, but I just feed into it. 9 times out of 10, if I'm calling a very difficult person that I need to consult, and especially if I know it's a stupid consult, but I have to do it anyways, I play into the whole, like, you're so smart. You're so smart. I have this patient, and I mean, the lactate's high. I know it's probably nothing, but I need to make sure that you're going to check this out and let them know. And I really could use an expert like you to look at it. I'm telling you, works every single time. Everybody likes to hear how smart they are. They may keep you on the phone longer than you want to, because at that point they want to keep talking, but they won't be a jerk to you. I promise you that, and get what you need. That was a little sidebar. Just described him to a T. Yeah, egos. There are a lot of egos in healthcare. I won't say medicine, because I see it from nursing aspect as well. I see it from all sides. We all have a lot of ego, and I don't know why. Scott, you tell me, when I was an ER nurse, you couldn't teach me nothing. I was the shit. I knew everything about everything. And I think it's just maybe a little bit protective down there. You got to kind of have a sense of commanding the room, or else those patients will run all over you. I don't know. I like to think that's what it was. I think it's just a culture thing, where I was also at a level 1 hospital. So it's a little different there. But yeah, I thought I knew a lot more than what I actually did know. It wasn't until 6 years later, when I started working in the ICU, that those nurses schooled me in the art of how much I didn't know. And I was like, oh God, I'm a big dummy. Yeah, egos. I don't like them. Okay, so we were talking about local complications, limb ischemia. The gut is also what I kind of consider local. So a lot of these people have, well, in my world, I work in a mixed ICU setting, but a lot of it is elderly population. As we age, there's so much more calcifications in all of our arteries throughout the whole body. Just look at a CT, like a, what is the sagittal view? The sagittal view? Frontal view, where you're looking at it head to toe, and look at the arteries and all the calcifications lining it. It's not just at the aorta, it is all the way down. And so a lot of times these folks, if they already have calcifications there, they're already pretty stenosed at this area, where the SMA takes off and starts to feed the rest of the gut. It only takes a little bit of low flow, low blood pressure state, low cardiac output, and then the mesenteric vasculature doesn't get fed, and so then the gut starts to die. You just don't notice it as quickly as you would like reduced urine output or confusion, because it's not immediate. They may start complaining of belly pain, they may have diarrhea, they may have constipation, they may have bloody stool. But what I see clinically is the lactate will start to rise first. This is really one of the first things I look at for somebody who's got a really, really high lactate. I look at the gut. Have we CT'd the abdomen recently? Because it just kind of gets missed. A lot of times these people are already sedated, or they can't recognize pain because they're already on pain meds, something like that. So high lactate, I look at the gut first. But obviously that's type A. It's very concerning, right? They're gonna get necrotic bowel, and people die from necrotic bowel if you don't take it out. Local trauma, crush injuries, burns, necrotizing fasciitis, which if you've ever taken care of someone like that, you will never forget it. It's pretty traumatizing. They just get more and more of their body cut off as it starts to get infected and die. Okay, so Scott said these people who think they know everything really annoy the rest of us. Exactly. MD schools teach you so much about how much you don't know. That's for sure. Yeah. Okay, I think I'm in the eye section, which is always the hardest part. What color should we do tonight? I'm cold today, even though it's pretty outside, but it's cold. So I am doing gray sweatshirt today. So what color eyes? Maybe I'll go with the pinkies, pinky pinkersons. Okay, and the last one is also overexertion, which this is where it gets confusing because I told you this can be type B, right? And it's because of that critical limb thing I was talking to you about, right? Like the poor young man who lost his legs, that's life and limb. So that falls in this type A category. But you can have an elevated lactate. Like it's quite often in my world that I'll get people who were found down, right? They were intoxicated or they were unconscious for a period of time and they have local injury that will drive up that lactate, but not necessarily induce a severe problem in that region or like systemic issues. So that's why it can be either or, just like really confusing, right? So again, clinical picture. And then there's a type B, which I'm not going to talk about, or not B, type D, pardon me, type D, which is super duper rare. And I really didn't even go into a bunch of research about it because I started reading about it and I was like, I've never seen this in my whole entire life. I don't think anyone ever has. So I'm not going to talk about it. It just confuses people. So then I kind of segued into talking, what do you do about it? So you get a call that someone has an elevated lactate level. What do you need to assess and how do you fix the lactate? So the first thing I said was getting a decent understanding of what type you have, which we just talked about. And then that it can also often be multifactorial. You can have multiple things that are raising the lactate and keeping there. You can have the alcoholic, for example. The alcohol is raising the lactate, but they may have been very hypovolemic during their binge drinking session where they were dry and they have low blood pressure. So they have a little bit of a systemic problem. So is that driving the lactate up or is the alcohol driving the lactate up? And then they may have been drinking for 1,000,000 years, so they've got liver damage. So is the liver damaged enough that it's not going to clear the lactate? So it's not always a super clear picture. But in general, not everybody that you get called to consult on with an elevated lactate needs to move to the ICU just because of that. So it's just a context thing. I'm kind of repeating myself over and over, aren't I? So what clinical signs did you assess? Signs of end organ failure, whether local or global. So local, I said, so the first thing I do, do we see anything, any kind of type of critical limb ischemia? Is sensory motor function intact or not? They have palpable pulses, cap refill. What's the color of the extremity, the temperature? Look for signs of bad infection. Now, I have never seen cellulitis drive up a lactate. It's just a local, it's a small portion of the skin that's infected. You'd be looking for something deeper, something that's going deeper to like an osteo, which is causing a lot of like local inflammation and tissue damage there. But you'd be looking for signs of infection, was my point. Hyperpigmentation, shiny, hairless limb, all those things you hear about with poor peripheral arterial disease. And the other local thing is the gut ischemia. Are they having belly pain, diarrhea, bloody, constipation? Do they have a fever? Do they have a CT? Oh, I did put a note in there that yes, that is regional. The gut is regional. But if you get to a point where you have necrosis, it may very likely be systemic. And then they've got like a massive, almost SIRS response where everything else is starting to shut down too. So it can progress to that. And then, okay, neck fascia. Talked about pain out of proportion to the exam. So I don't know if you ever had a neck fascia patient, but they have excruciating pain. Like you won't see hardly anything on the skin. You may not see much at all. But if you touch their, wherever it is, they will jump off the bed. Every true neck fascia I've ever had, that's been the situation. Again, I know that's anecdotal, but I think that's pretty proven too. So that would be like the local stuff I'd be looking for. And then global. So again, going through the systems, what organs are failing and how bad are they? Multi-system organ failure equals badness. Yes, it does. Cap refill, oliguria, confusion, which is the triad of badness. Because again, those are the non-protected organs. So you start by assessing those and then looking at the periphery, decreased distal pulses, skin color, in regards to having like all over poor perfusion, like not regional poor perfusion issues. Modeling, which is interesting. I was talking to one of the gurus that started my program because I find modeling to be fascinating. Typically speaking, it starts in the lower extremities and works its way up. And I will tell you, in my world, when someone is modeled and the modeling is going up to the knees or above, that's like pathognomonic for badness. Like they about to die. Modeling is, to me, one of the scariest things that I see pattern recognition wise. And I've done research on it before because, I've investigated it a little bit before to see what studies are out there because it's just so, to me, highly correlated. I can't find anything. Let me know if y'all find some information about that because I would be fascinated to know, has anyone done studies to show the correlation of how many people die once they develop modeling? Happens all the time. It's really, really concerning looking too. And then diagnostics. So this is looking at trying to determine what your cardiac output index is, whether or not a patient is volume responsive, all of those kind of factors which get really deep. So we're talking like your mixed venous, your SCVO2, a FIC, a dirty FIC, which can be calculated from a mixed venous on a central line. If you have a SWAN, of course, that's great. You can always look right away and see what your COCI is there. Your PA pressures is always nice to know what your right and left sided heart pressures are. And then measures of volume responsiveness, like an SVV or a pulse pressure variation on your arterial line, and or a maneuver like a passive leg raise, which I guess we could talk about those a little bit. They get a little complicated, but if there's one thing to determine whether or not a patient, what their current volume status is one thing, but determining whether or not giving them more fluid is going to benefit the output, like the stroke volume, the cardiac output, and the blood pressure is a different story. Because just because those numbers are low doesn't mean that they will respond to more fluid. So these are things you're talking about, like dynamic measures of fluid responsiveness. This is your stroke volume variation. So multiple things can tell you this. What I do in practice is this. If I have a bedside ultrasound, I'll go in, I'll look at the IJ. What does it look like? When I'm positioning someone for putting a central line in the neck, they're generally laying flat. I look at these a million times a day, so I know what they look like. If I lay a person flat and this is engorged, they probably got some volume, but you could probably also see that by looking for a JVD, right? So, you don't necessarily have to do all this invasive stuff. I'll also put it on the cardiac windows, although admittedly I suck at cardiac windows, but I can tell if the tank is full or if it's pretty empty or if the pump is good or bad. That's about the extent of what I can tell you from the heart. You can look at the hepatic vein. You can look at the IVC to see if it's collapsible with a deep breath in or a high tidal volume on the ventilator. That increased intrathoracic pressure should make those vessels squeeze down a little bit. So you should see like a little bit of this. But if you see a lot of it, more than like 50% of it collapsing down on itself, they're dry. So that indicates that if you give them some volume, it'll pump back up. There are devices that will measure this, and the validity of them goes back and forth on who you talk to. But these typically will attach there. So there's bioimpedance things, like little stuff you can stick on different parts. I've never used any of those in my hospital setting, but I've heard of them. And then there are devices that you hook up to the art line, and it looks at the tracing of the art line and looks for variation when there's a high tidal volume or high breath that comes in, and whether or not that variation in the stroke volume is going up and down enough to a degree that it would say this person's on the dry end, they would probably respond. And they say higher than like 10 to 15 is high. High is dry. So this is an SVV. One other thing, but there are things that eliminate that. Like, so if they're in AFib or if they're breathing spontaneously, you can't use that. So they basically got to be on vent and not breathing and in sinus rhythm, which eliminates a lot of people. But what you can do is turn that on, look at the waveform, look at the stroke volume, not the SVV, but the stroke volume. Do a passive leg raise where they're kind of sitting upright, and then you shift them this way where the legs are 30, 45 degrees higher than the heart. Wait about a minute or so and see if the numbers improve. Does the SVV go down? Does the stroke volume go up? Does the blood pressure go up? because this is equivalent to about 250 cc's of an autobolus. So it's like taking, our veins hold a lot of the fluid in our body. It all pools there, particularly when you're laying down. So if you lift it up, then you get about a 250 cc autobolus up to the heart, pumps out, gives you a little more preload. And if you see an improvement from that, you've kind of safely done a little test without giving them extra volume. So it's widely accepted. People use it a lot. There's just a lot of exclusionary factors like we already talked about. There's the other thing too is something called a Moro reflex. I'm pretty sure that's what it's called, where like babies is a startle reflex. If you lift their legs up, they kind of startle. That will make your heart rate go up, which will make your stroke volume go up. So if they do that, you can't use it. So again, a lot of exclusionary factors. So there's no one piece. There's no one piece. You just put a lot of different things together to help you determine whether or not you think this person is going to be volume responsive or not. And that is how I decide whether or not a patient needs 30 cc's per kg of fluid, not the lactate level. Just saying. I mean, we don't have access to all of those things quickly, right? So you got to put it all into context and use what you've got, but it's just one number. So when you're working this patient up, I start by, okay, so they got an elevated lactate. Is there a metabolic acidosis? So look at the metabolic panel. So your CMP, your BMP. Look at your CO2 on that, which is actually not carbon dioxide. Well, that's bicarb. That is serum bicarb, and that is comprised of 90%. That is comprised of 90, is it 95 or 90%? It's 95% bicarb and 5% CO2 and carbonic acid. Why the labs call it CO2 because of that 5%, I don't know. It's bicarb. So if your bicarb is low on your serum venous labs, you have an acidosis. You have a metabolic acidosis. I haven't, but I do know that you can. And 802 Mer says, have you ever tried the passive leg raise while the patient has end-tidal CO2 monitoring? I haven't used it for that purpose, but I do love end-tidals. End-tidals are a sort of surrogate marker for cardiac output, which is why we hook it up to people when they're in cardiac arrest, because if you see the number suddenly change, then they either got ROSC back or they're losing it again. So in theory, I can absolutely see how it would work. I'm just trying to think how the spontaneously breathing person. Yeah, I could see it. I've never used it that way though, but yeah, I could totally see it. There are a lot of different ways to help determine. There are a lot of safer ways than just giving a fluid bolus and seeing what happens, which isn't necessarily the wrong thing. Okay, I don't want this to sound like I don't ever go in and say, let's get 500 and see what. Plenty of times I've done that. Because a lot of the time, it is a little bit of a guess, even with all of your data. But I think as long as you're doing it in aliquots like that, 250, 500 mLs, and you're basing it on something more than just a knee-jerk response of giving fluids, as well as what your end goals are, then I think it's reasonable. Particularly if you have suspicion for hypovolemia. It's an old school back of the ambulance trick. I like it. Every tool I can get in my toolkit, because if you have something already there, the worst thing in the world is to say to a nurse or a couple nurses who are in a room of a patient who's crashing, hey, I want to take time and set up a flow track. Well, that's like a 30-minute process. So whatever I can use that is quick, that's rapid, that will help give me a good picture of things without having this dogma of being stuck to doing things just one way, because that's what I'm familiar with. I don't think that's good medicine. Okay, so is there metabolic acidosis? Check the pH and the anion gap. So you also want to know if it's anion gap acidosis or not. Different differentials for each. Is the kidney or liver injured? This will delay clearance. Look up the labs. Yeah, this is the part where I'm starting to walk you through how I approach things when people call me for an elevated lactate. This is kind of what I'm doing. Like, is there metabolic acidosis associated with it? Is there something there that's going to prevent this lactate from clearing? I've also already looked at why I think it's high, right? Is this patient acutely intoxicated on alcohol? Might be it. Then doing the exam, all the things we talked about before, local and regional stuff, local, regional, and systemic stuff. The labs, mixed venous, COCI, increased LFTs. troponin elevation, creatinine, GFR, pH, anion gap, glucose, potassium, toxic alcohol levels. Okay, on and on and on. I could just read all this out to you, but basically just looking at all the labs. Medications that they're on currently, and history, of course. Do they have cancer? Diagnostics. So I do love a good echo. I feel like in my world, most people should have one good echo during most admissions. Cardiologists would probably hate me for that. Like, why are you getting another echo? Because I need a thorough, we don't do PA cats anymore. We don't do swans anymore. So I need at least one good assessment of all my filling pressures, of the valve, evaluation of the valves, the pulmonary hypertension, so that I can get a feel for where this person is kind of at. And I can't get that with a bedside focus. You just can't. You can't. And then figuring out the type of lactic acidosis and the etiology. I actually already talked about that. If it is shock, do everything in your power to accurately identify the type of shock and narrow your treatment plan. I can't harp on that enough. And this goes back to how I started this with, don't just throw fluids at them. If it's cardiogenic shock and they have an EF of 20%, they could actually be dry. You don't know. They could be dry. This could have been a person at home who hasn't eaten in many days or has had diarrhea. They could absolutely be dry. You don't know until you assess volume status. Which, as we said, is complicated. But you can also put in a central line, get a mixed venous, and see how that's looking. Other signs of, the old school way of determining whether or not a patient is cardiogenic or septic shock. Have you ever heard this? This is one of the first things I was ever taught when I became an NP. The doctor I worked with was like, Brianna, go in that room. You can look at the monitor if you want to, but only by touching the patient, I want you to tell me what type of shock this patient has. And I was like, oh my God. And then it came back to me. So I'll pause for dramatic effect for a moment, see if you'll know. This is kind of an oldie but goodie. MERS, 802 MERS, you might know this. But yeah, I don't know the validity of it, but I do pay attention to it. I do find that every single time I see a new patient, I put my hands on their hands and their feet. I'm looking for whether or not the patient is warm or cold and wet or dry. Warm and wet, cardiogenic shock, early cardiogenic shock. Warm and dry, probably septic. Cold and wet, probably, if they're wet with it, probably on the early to mid stage cardiogenic shock. If they are wet and cold, late stage cardiogenic shock. I don't know how valid that is, but I still use it. It's one piece of data. Old sepsis is cold sepsis. Yeah, you can be. Once you get to late stage where they're not perfusing anything, for sure. Early stage, you'll have that fever. So that's why I say the warm, but late stage, absolutely. What else? Okay, I put a little side note on here that I was going to talk about too, because I have a doctor who likes to talk about this a lot. Would you give someone with an elevated lactate lactated ringers or not, and why? Okay, I think I gotta do my eyes. I did part of my eyes. I gotta do the mascara part, which I gotta look at this first. I'll let y'all think for a minute while I put this on here. This one, as well as the potassium level, how much potassium is in lactate. So many people against the lactated ringers, I should say, which is a balanced solution. I really kind of like it a little better, particularly in somebody that we're resuscitating the heck out of. If you give too much normal saline, you're giving a lot of chloride, you're going to worsen acidosis, especially if they're not able to ventilate off CO2, because bicarb breaks down into CO2 and water. So if they can't blow off the CO2, you're going to make a patient who's got respiratory acidosis worse by giving them bicarb, which you shouldn't give. You should give it for metabolic acidosis. Okay. Stream of consciousness here, guys. Good question. D5LR is my fluid of choice. D5LR. Yeah, okay. Well, you probably do need to give some sugar to your ladies. So lactated ringers will not drive up a lactic acid level. It doesn't break down the same way. And even with that, it's only a very small number that you're giving them. And the same thing is true for potassium. There is only like, I'm going to say wrong. I want to say it's like 4 milliequivalents of potassium in a whole bag of LR. You're not going to drive up their potassium by giving them LR. NS all the way. It's sodium lactate, not lactic acid. Exactly. I asked my ER doc that my lactate was elevated and he ordered lactated ringers. Yeah, it's not going to drive it up. It won't. It's a different type. And if they have an elevated lactate and they're probably acidotic, it's the best thing for them, because if you give them NS, you're giving them that chloride, you're going to make the acidosis worse. So LR is probably a better solution for that person. I mean, there are other factors that you're looking at. So, Mr. Midwife brought up the D5LR thing. So D5, if you have a high sodium level, giving someone a dextrose infusion will help bring your sodium down. It's free water. You're so dang smart. Oh, you're invited to come back anytime you want. You were the patient. Oh, how funny. What did he tell you? Did he tell you it was okay? Or did he tell you the wrong thing? Good questioning, though. I love it when nurses ask me a question. I really do. I've worked with some people, and I've known some people who maybe feel like it's pushback, but I've never seen it that way. And I also was that kind of nurse. I'm very much I need to understand the whys behind things. So 9 times out of 10, when I'm asking a question, it is because I just genuinely need to understand it the way that they understand it. But again, with egos, some people see that as questioning their authority. Not everyone is as emotionally intelligent as we find folks are. That's, it's just the way it is in life. In fact, I think the vast majority of people struggle with insight. Certainly in the healthcare realm, one of the things about becoming an NP that, I guess I knew, it's just, there's some things going into a situation, they're there. You just kind of don't anticipate how much of an impact it'll be. But one of those is that, being an NP, your role is so different. You're not a nurse anymore, but you still have that root there. But you're working alongside physicians and you're acting more like a physician than you are a nurse. But yet you got to deal with the physician personality. I don't remember, but he said it wouldn't affect the lactate. Cool. He was right. I'm a dummy. I learn from anyone. Same. We all have expertise to share. Okay, where are we at time-wise? 1 hour and 3 minutes. Okay. I think that's all I have on lactate. I did in the blog, I put like 4 or 5 references of different articles that would probably be helpful too if you're interested in more of that kind of thing. So you're not just taking it from me. There was something else I was going to tell. Oh, I know what it was. Last week, I really kind of hated it that I missed last week because I did want to talk a little bit about provider decision fatigue. But the big thing is I wanted to say about that was when I was doing research about decision fatigue, a friend of mine told me to do this subject because I said, what would you say was the hardest thing? What would you have wanted to know going into being an NP that you didn't know? And he's like, I wish I had known that the decision fatigue was as severe as it is and that it was okay. I'm like, you didn't know it was okay? No, I don't think you realize how severe it's going to be until you get there. But you see your colleagues not going through quite as much of it, and you start to doubt yourself. But so anyway, so I was writing this article. I did some research on decision fatigue, like where the ideal came about, where the studies were done, and this is fascinating to me. Y'all, listen to this. Okay, there was a study that was done. I did not write down the year. Sorry, guys. There was a study that was done, performed on parole board judges. And they found that the largest impact on whether or not parole was granted was the time of day. The time of day. Okay, what? So, not the type of crime, but the time at which the case was reviewed. So, if the prisoner was seen early in the day, 70% of the time they were awarded parole. But by the time late afternoon rolled around, only 10% were paroled. I mean, I'm not saying they all need to be paroled, but I guess because the judges were having a harder time assessing the situation and feeling confident in their decision, they just elected not to parole them. That's fascinating to me. I would have never guessed that in a million years. But I talked about that in this article because the thing about decision fatigue is earlier in the day, it's not so overwhelming to make hard choices. But as the day goes on, it gets really, really hard to make choices to the point that as a new NP, I would come home from work late. I was late every day. Walk in the door and my kids would be like, what are we having for dinner? What can I go to my friend's house? And I would like completely shut down. Like, I don't know. And I can't answer that question. Like, I have no idea. Don't ask me anything even simple because my brain is fried. That's the piece of being a new NP that I didn't fully anticipate. Mr. Midwife says very severe with decision fatigue as your coffee wears off. That too. Yep. 802 Merce says volume is fine with a bit of NS, but a massive or sus NS. Exactly. It's when you give large volumes of NS that the chloride level raises your acidosis, lowers your pH, raises your acidosis. That's not coming out right, but you get what I'm saying. And for somebody who's already acidotic, it's just not where you want to put them. All right, so that's all I've got for y'all today. I have no idea what next week is going to be. Haven't even considered it. I'm still just celebrating finishing the dang book, which is like getting my life back. Oh, that was one other thing I was going to bring up. Did you guys see? You probably did because y'all read the news more than I do. But it was last week that Utah. Hold on. I'm just reading it. I don't want to say it wrong though, so I got to pull it up. Utah was the 27th state to adopt full practice authority. 27th state. That's pretty dang cool. I used to be kind of like torn about the whole FPA thing. Like, do NPs really need to have full practice authority? Like, is this safe for patients? Isn't the healthcare model, blah, blah, blah. But I have since changed my tune for sure. So I love it. I celebrate whenever we get another state that, awesome. I did not know that. That's awesome. California did. I'm pretty sure Georgia, we're in the Bible Belt. So from now until hell freezes over, we will be under the thumb of a physician, which again, I think all things with a grain of salt in life, right? Nothing's all good or bad. If you work in a hospital setting, you need to have a collaborating physician. You just do. But if you're doing, primary care in a critical access hospital where people aren't going to have access to health care, you are doing a great service to humankind. I do not think safety is risk there. Same thing with like a specialty niche practice. If you're opening an IV hydration clinic, you don't need a physician to oversee that. It's just all in perspective. So I think the more that we make it easier for people to be allowed to practice medicine when they're capable of doing so, the better it will be for humankind and for people who cannot get access to healthcare. Finally, Utah gets something right. Oh, California State. Is California one of those where you have to like have a couple years where you like a not probationary, like a period of time where you prove that you I forget the words. The words aren't coming to me, y'all. Scott says never say never. There's a bill for full practice authority being debated in my home state of Missouri. Interesting. Yeah, Missouri's down here near us. I like an MDO in my back pocket. Just don't force it. Same. Yeah. Same. I've always talked about and promoted a healthcare model that's like a pyramid where you have a physician at the helm and multiple layers underneath and multiple different types of mid-levels, multiple different types and scopes of nurses, all the other different specialties and how they add to it. But I think as the physician shortage gets worse and worse and worse, it's going to become more of this pyramid effect where physicians are going to really just effectively be overseers. And I think that that's okay. I mean, I think that we have proven that as NPs, we can give quality care just as good as our physician colleagues can. So with the right level of training, I do think we need to get standardization of our training first. But I still celebrate when we get another FPA state. I still celebrate it. All right, so an hour, 10 minutes. I think I've rambled enough. Thanks for coming, y'all. 802 Merce says Vermont has, but it's 2,400 hours. Yes, supervised practice, and it resets from transition. Oh, God, really? I mean, I guess that makes sense because we're so specialized in what we learn. Scott said 3 years. Okay, in California, 3 years that an NP can practice without standardized procedures in a group practice, 3 or more years. I mean, I'll give it to you. That's more than we got here in Georgia. So I think that's actually not a terrible plan because it's giving you an opportunity to prove that, to develop your expertise, prove that you can do what you're saying you're doing and do it safely. So yeah, I could get on board with that for sure. All right, if y'all come up with any ideas you want me to talk about in the blog next week, let me know. It'll probably be something professional because I try and balance out the clinical and the professional stuff, and I don't know what it'll be. And inspiration just strikes sometimes. When it strikes, you don't question these things. All right, guys, thanks. The lip liner. Yeah, I've got it in my hand. I just didn't do it. Got to have the full effect, right? I know you guys come here for the makeup. It's not for the intelligent speech or even the fabulous community. I'm sure it's just to see the products of the makeup, the beauty influencer in the making. My favoriteest beauty product owner has gone out of business, and I'm very sad. Oh gosh, I don't do as good a job when y'all are watching. I think it's the pressure. Typically in real life, it's better than this. I'm smart. Doctors are smarter. Well, some of them. 75, 100% of your audience today has been male. I know. I know. Who was I telling this to? Oh, my daughter the other day. I was like, it's like Get Ready With Me, which she loves the idea. I'm like, yeah, but it's mostly dudes who come there. So I don't really know what they're getting out of that makeup piece of things, but it makes me feel good about myself. Okay, guys, I will see y'all next week. Y'all have a lovely weekend. Pray that the hospital isn't as bad tonight as it was yesterday during the day. I don't know why it's so bad lately. Ta-ta for now.